Good day. My name is Daniel Foreman from University of Pittsburgh in the United States. Welcome to the Frailty Seminar Series of the Global Frailty Network. Today's webinar is on cardiovascular disease and frailty, and I'll be speaking along with colleagues Quinn Denfield and Oliver Todd. First, a few housekeeping issues I've been asked to relate is that please use the WebEx chat button if you'd like to ask questions to any of our speakers. If you are a clinician practicing in the USA or Canada, you can claim AMA PRA credits. You will receive instructions at the end of the webinar. So now for the brief introductions of the three speakers. Myself, Daniel Foreman, Professor of Medicine at University of Pittsburgh. I'm in the divisions of cardiology as well as geriatrics. I'm also on faculty at the VA Pittsburgh Healthcare System in the GREC, the Geriatric Research Education and Clinical Center. My career is focused on the interface between cardiology and geriatrics, both clinical and biological, with particular interest in maintaining physical function in older adults with cardiovascular disease, despite frailty and other complexities. Dr. Quinn Denfield is an associate professor in the Oregon Health and Science University School of Medicine. She has a secondary appointment in the School of Medicine, the Division of Cardiovascular Medicine. Her research focuses on the biobehavioral mechanisms of symptoms and frailty among adults with heart failure, particularly women and older adults. And Dr. Oliver Todd is an honorary consultant at the Bradford Teaching Hospitals and clinical associate professor in geriatric medicine at the University of Leeds in the United Kingdom. So to highlight, you have a cardiologist geriatrician and myself, a nurse and a geriatrician internist among the three speakers, providing different perspectives on the topic. So I'm going to share my slides, hopefully. I hope you all see my slides. I can't see you, so I'm going to go forward, but just let me know if you can't see them. But I'm going to be speaking on the impact of frailty on the practice of cardiovascular medicine. I have no conflicts of interest, and my disclosures are that I'm just funded by the NIH and the VA and PCORI for a related interest in this theme. And I start most of my talks with a focus on demographics to kind of highlight what I think is probably very familiar to this audience, is that with age, the prevalence of cardiovascular disease skyrockets in women and men. And as the worldwide population is growing older, the implications of this are quite profound in terms of management of cardiovascular disease and really just management of disease in general. I want to highlight my talk, or really give perspective in terms of my own career. I'm the oldest of the three speakers, and I kind of lived through the evolution of cardiovascular disease and frailty as a theme in the management of cardiovascular patients. This paper, published in 2011, was written at a time when I was really a very traditional cardiologist, practicing, doing stress tests and other clinical dimensions of care routinely. But it became very apparent to me in the course of my work that age was the driving factor in many outcomes for many patients. And this was kind of off the radar for most of my very esteemed colleagues in Boston at the time. So the issues of so many dimensions of care, frailty, yes, which really wasn't in the radar of cardiologists, as well as multimorbidity, polypharmacy, cognition. There were multiple providers. There were very different priorities of care among the patients themselves than the cardiologists, who tended to focus on MACE, major adverse cardiovascular events, whereas patients were concerned about independence, they were concerned about cost, they were concerned about so many things that the cardiologists really didn't speak to. And so the whole notion in my mind of best care started to change. The other thing which happened over the last 10 or 15 years was the fact that we started to think about aging itself very differently. There was the fledgling science of geroscience. At the time, it wasn't coined, that expression hadn't been coined, but there was the recognition as depicted by this schematic, which I see as somewhat of an icon for what has become geroscience. This is by Carlos Lopez-Aten. And he shows that there are various factors that really drive aging. There's genomics and epigenetics, and there's changes in mitochondria, proteostasis, senescence. They were all newly recognized and shown to really change the way people age and the way aging occurs in general. It was a 10-year anniversary of that article in Cell, and it showed over the last 10 years how much has gone on in this field and how much it's really profoundly changed the way we think of biology in general, of aging, and it really encompasses both cardiovascular disease and frailty as we understand them. I've had my own kind of anniversary as well. I talked about that white paper in 2011. This published a little bit recent, or a little bit more than 10 years, really highlighting my work with my colleagues, Dr. Kushel and Ferrucci, really showing how the geroscience has impacted cardiovascular disease, as well as non-cardiovascular disease and frailty, how they impact care with new opportunities for treatment. But as you want to think about frailty and cardiovascular disease, I think in terms of what has really happened over the last 10 or 15 years, I think the advent of the transcatheter aortic valve replacement, TAVR as it's called in the United States, TAVI with implantation instead of the replacement in Europe and much of the world, I think this is really important to highlight. This disease, aortic stenosis, is something which occurs with aging, really generated by some of those geroscience factors. You have suddenly older adults prone to this valve stenosis with very poor clinical outcomes. And the only way to treat this at the time was surgery. But many of the patients, actually most of the patients, were deemed too frail, too enfeebled to undergo surgery, and they were left to languish and die. And suddenly, about 2010-11, with the advent of TAVR, with the opportunity for using a new approach that involved replacing the valve through a catheter without the burden of surgery. And as you see in the data on the right, patients could not weather surgery. These patients were moderate to high surgical risk with a Society of Thoracic Surgery score that was high, but they could endure TAVR. And suddenly there was an explosion of new patients, new opportunities for busy cardiologists to suddenly think about treating. But this really gave rise to a new perspective. These are old data, and this is a landmark paper by John Appalalo and others, but it really highlights his, as a very young investigator in the world of cardiology, kind of saw this as a very interesting phenomenon, because the surgical outcomes on the left, they've improved. The catheter techniques and so many things about the procedure themselves have really evolved. But the two graphs on the right and the middle and the right have not really improved that much. New York Heart Association class and Kansas City cardiomyopathy scores looking at function and quality of life respectively really don't show massive improvements even after this beautiful valve is deployed. And it kind of set up the premise for the first time that there are patients for whom TAVR is beneficial and for whom it really is not useful. And there's something in the middle that determines that. And it's not something which cardiologists have ever measured. And it became recognized that this notion of frailty, which was already kind of embedded in the geriatric literature, was very relevant for cardiologists. And it really has catapulted the field in many ways in cardiology and other fields of specialty care as we understand how to best treat or how to think about treating older patients differently. John Appalalo published this picture as part of this paper, and I think it's the first of like dozens, probably hundreds of similar schematics since that have really tried to show the interplay between the understanding of frailty as described by Fried and Jeremy Walston with inflammation and androgen deficiency and insulin resistance and muscle composition changes, and the overlap with what we started to understand about cardiology born of an inflammatory process with a multi-system dysfunction, with an overlap with the phenotype that kind of converges between them. So it's not just frailty, it's frailty and disease with a convergence. And growing sophistication about that. Linda Fried gave a wonderful lecture as part of this seminar, and she's just done wonderful work for decades. And showing here that these notions of mitochondrial function or dysfunction and cellular senescence and intracellular communication have effects downstream on muscles, on metabolism, and autonomic nervous system to generate the phenotype. What I'm really highlighting is that what she didn't talk about as much as I would and do now is that it's not just those three particular mechanisms, it's all the hallmarks of aging. They all interact with each other. They all generate interactive effects. And it's not just the frailty phenotype, it's throughout the system, including the heart and every other part of the body. So it really is adding to the complexity. I want to show two other schematics, which I think are both conceptually very important. This is by Ed Licata. When he did this, he was the cardiologist, the head of the intramural cardiology program of the NIA, National Institute of Aging. And he shows age on the x-axis, and he shows the sense of vulnerability borne by the hallmarks of age over time. And he shows that ultimately, most people are susceptible to disease, cardiovascular disease in the context of multimorbidity as they get older. The wavy lines are meant to represent resilience. This is a key point, that resilience can really forestall the effects of the hallmarks of aging, but that ultimately most people are susceptible to multimorbidity, cardiovascular disease, and other diseases, and that the same exact pathophysiology generates frailty. They both are born of exhausted functional reserve, and they are both likely to occur with aging. It's not aging alone. My last schematic on this concept is this one that I did with really crediting Dr. Ferrucci again. The bottom of the graph, this is really not that new. I mean, it's the same concepts I've kind of just been articulating, the hallmarks of aging in the face of diminished resilience, predisposing to cardiovascular and non-cardiovascular diseases, as well as frailty, as well as disability. But what I want to emphasize here, and this is really the work that Dr. Ferrucci and others have really championed, is the bidirectionality of it. That when you have cardiovascular disease and you treat it, you can moderate the effect of additional hallmarks, so that it's not just a process that goes in a linear way forward, but it's one that's bidirectional and opens many opportunities for intervening on the frailty itself. And likewise, the risk factors and the lifestyle factors are also bidirectional. And so all of these processes are interactive in a very complex biology. So when a cardiologist thinks about deploying a stent or doing a procedure, which is what cardiologists tend to like to do, is really much more going on that's relevant in terms of best outcomes and long-term benefit for the patients. And I would say this really should be kind of incorporated into every aspect of what cardiologists do, but it really has been slow. Despite the fact that progression over the 10 years I've mentioned, it has not been as quick as I think many other advances have occurred simultaneously. I think one of the key issues for me, as I see it, is the conundrum of frailty diagnosis. We have, as this audience knows, the phenotype, the deficit accumulation index, and there's many different variations thereof, and wonderful talks that we've heard by Linda Fried and by Ken Rockwood and many other experts. But there's really no definitive solution that works for all. This is Deirdre O'Neill and I worked together on this list. Deirdre did most of the work for this particular table, showing just some of the many different ways of looking at frailty that are in the cardiovascular literature. So when a cardiologist is deploying a stent, you know, in the rush of an emergency case, when he or she is when it's a tertiary event and or a transfer of a patient, how does that cardiologist really incorporate frailty in an actionable way and in a way that can be reliable? This is, you know, the equivalent would be a troponin level. You can act on that, but this is not at all actionable for most cardiologists. So I think that's really been a dilemma. And I think this is actually a symptom of the problem, that the fact that we still use in a routine way Ken Rockwood's clinical frailty scale with these little clip arts of people as if this is going to really describe frailty, I think is rather primitive relative to the sophistication of the science as we now know it. And I think it's really problematic because these clip arts can be really distorted, and they can be a source of bias, especially when people have lower socioeconomic status or they're kyphotic with osteoporosis and other issues. So I think that we may do our patients a disservice by miscategorizing them as relatively more or less frail based upon this kind of primitive assessment. I think this is very important because many people assume that frailty is futility, because John Apolello and other people's work have shown poorer outcomes in many cases when people are frail. So this may lead to an undertreatment, when in fact we've also argued that frailty may be treated in a way that's bidirectional if we're more aggressive with treatment of cardiovascular disease. So it's problematic. Another issue I'd like to highlight is that most cardiologists have looked at major adverse cardiovascular endpoints as their kind of the benchmark of best science. And as we think about frailty being so embedded with cardiovascular disease and aging, I would say that when we look at it, the endpoint really should be broadened. Frailty is associated with loss of independence, disability, and other endpoints that are really very important to patients. And this work by Abdullah Demlouji really shows that patients with cardiovascular disease who are frail have much worse outcomes when they are frail. And this is really of importance to our patients when we think about treating them. This is I like this slide because it captures so much work. Dimitri Richter did this recently. And I'm just going to touch upon the science that's embedded in this in my brief talk. Frailty has impact on every aspect of cardiovascular disease management, and across this spectrum of chronic coronary disease and peripheral arterial disease, heart failure, arrhythmias, valve disease. There's arguments that Afalalo and many other people have described where if someone is frail, they may tolerate the procedure or the medication less well. And in many cases, that leads to the reluctance to give the antithrombin therapy or other therapies that may cause bleeding or falls or poor outcomes, longer hospitalizations, more costs. There's a whole smorgasbord of things people worry about. But at the same time, the literature now is also arguing that if the dose is moderated, if it's well timed, if there's nuance in the administration, it can be given better and really forestall frailty and have better outcomes for the patients that are frail that have cardiovascular events. So I think that the issues really are complicated, and they're, again, bidirectional, and they have to be nuanced for each patient in ways that take a lot of thought to do well. I think it's problematic, as this diagram shows, that it's all couched in the midst of end-of-life decisions. You see on the left. I think frequently that leads to a very well-intended thought process to go to palliative care. And I think that it's important that palliative care not lose the perspective of geriatric cardiology, which really embraces the fact that patients can be treated aggressively, even when you want to administer care that's best for their well-being and symptomatic relief. And I also want to highlight on the right that there's growing sophistication and thought about shared decision goals. These really are complicated decisions that we must make with our patients. They can't be done unilaterally, and really being attuned to what the patient wants. And there's a growing sophistication about digital health tools that can really try to sort out some of these issues in the moment of how frail somebody is and what's modifiable. I want to highlight this dimension. This is work recently published by Butt that shows that, for patients that have heart failure with reduced ejection fraction, that are already on many pills, the notion of giving yet a new pill, the new pill on the block, the gliflozins, in this case, dapagliflozin, it actually improved issues of frailty for those that are the most frail. So this is looking at functional outcomes in terms of all these activities of living, and it shows that by giving this drug to those that are the most frail, they gain the most benefit. So instead of like backing off for people that are frail, this really opens and really advances the perspective that treating people aggressively because they are frail is really an important one to consider. And the same kind of thought goes into this work by my friend and colleague, Delane Kitzman, and his colleagues, physical therapist Pam Duncan and Amy Pastava, who showed in the rehab heart failure trial an aggressive activity regimen was very effective in modifying balance, strength, mobility, endurance, all these elements of frailty in patients that were frail, particularly in HFpEF patients who had the greatest frailty to begin with. Significant benefits. This is not cardiac rehab. This is administering exercise like a medication in a way that may be used in cardiac rehab, but this is pure exercise as a way of modifying frailty. And so I would argue now the thought process is to treat frailty aggressively in those that have disease and even preemptively. This work by Abdullah Demlouji shows that people are frail, are more likely to develop cardiovascular disease, and they're more likely to develop cardiovascular disease events. It's the same biology, it's the same vulnerability, and so we should be more aggressive about treating it. This is a paper that I did with George Cashel and others that really shows that by treating with basic preventive strategies that are embraced by the American Heart Association, with activity and diet and various other factors, treating cholesterol perhaps among them, you can modify some of the hallmarks of aging, and you can really best achieve what many patients say is the most meaningful outcome for themselves in terms of the 5 M's. What matters most: mobility, mind being sharp, medications that are the right medications, not for each disease, but for the patient in aggregate. And so really trying to put these conceptual goals together with a prevention strategy tailored particularly for older adults, I think is a very important concept to advance as the field goes forward. And then in my last comments, I want to talk about the related thought about geroscience evolving towards gerotherapeutics. This was the paper that I mentioned at the onset as a thought process. What do we do now is that we know about more geroscience mechanisms to really moderate cardiovascular disease and frailty with the same therapeutic. So this is a busy slide, beautiful slide by Dr. Ferrucci, and in which the top half really encapsulates all these issues of geroscience mechanisms. We see the genetics, the inflammation, senescence, and all these other mechanisms converging and a common biomarker of inflammation as a hallmark sign of aging or a driver of aging with downstream effects that include disease and includes frailty and includes physical disability. So the thought process is if you can treat inflammation, you can probably forestall or stop all these things in ways that are really pretty powerful. So this was kind of a principle that was really demonstrated in many ways by Paul Ritker's work in this CANTOS trial, in which he used a drug, canakinumab, in a population that had high inflammation measured by C-reactive protein. And he showed that using this, the mechanism was going after inflammation with interleukin beta-1 inhibition. And it showed a powerful proof of concept that you could reduce cardiovascular disease events. This was powerful as far as the world was concerned, but what made it more powerful for this talk is that in the same week, the same drug in the same cohort also reduced incidence of lung cancer and it reduced mortality of lung cancer. And subsequently, in other studies, in the same drug, in the same population, reduced hospitalizations for heart failure, anemia, gout, arthritis, so many benefits by treating inflammation. So Ariella Orkaby and others, again, including Dr. Ritker, focused on the same principle, can this also moderate frailty? And it didn't work. This was looked at pretty comprehensively, really giving most of the credit to Ariella Orkaby with a frailty index and a phenotype assessment. There was no budging. So the concept is compelling. If we can treat inflammation, we can perhaps treat a lot of things, but we haven't really pushed the envelope yet on the frailty cardiology interlinking. This has led to many considerations. Is it the wrong drug? Was it administered the wrong way? Is the timing it's important to consider? Should it be done with activity? There's many things to consider, but we don't have an answer yet. That would be easy for what's really a very complex field. So in conclusion, the cardiovascular disease and frailty are interrelated. They are biologically driven. They're clinically linked. Frailty is prognostic, and it has management implications. It can mean being less aggressive because people may be more prone to falls and bad outcomes, or it could be more aggressive because they may benefit the most with greatest absolute risk benefit. And it really evokes the need for precision science and shared decisions. And the endpoints are cardiovascular, aggregate health, body composition, and function, both physical and cognitive. And really, there's a huge opportunity for novel therapeutic approaches, primary and secondary. And there's an evolving sophistication of geroscience as it impacts care. Thank you very much.
Thank you, Dr. Foreman. So I will share my slides here. All right, can everyone see those up there? Okay. Oh. Right. So today, what I'm going to be talking about will hopefully, I believe, dovetail really nicely on Dr. Foreman's talk. I'm going to be focusing specifically on assessing and managing frailty among patients with heart failure. So here's a brief outline of what I'll try to cover in the next 15 minutes or so. So I'll talk about the prevalence, the prognosis, and the very possible mechanisms of frailty. Then I'll discuss the assessment of heart failure, which I agree with Dr. Foreman in that it's variable and it's not well standardized. And so trying to move this forward has been a bit of a challenge, but I'll present our consensus statement on this. Then I'll talk about the management of frailty in patients with heart failure, as well as the management of heart failure in patients with frailty. So to get back to Dr. Foreman's point about the bidirectionality of frailty and heart failure. As a side note, this is a picture of my grandfather up here in the years leading up to his death. He was very frail. His frailty was a result of cancer and rheumatoid arthritis and age, among other factors, but I saw how it really affected him, and it's been my North Star for doing this work. I also want to point out that while this presentation is about heart failure, many of these points can be applied to other cardiovascular diseases. So first, I want to highlight a few things. First, we know that frailty is highly prevalent, but how prevalent was a question that I had when I first started studying this area. And so this is a little bit of my evolution of this work as well. So I noticed when I first started studying this around 2014, 2015, that the estimates of frailty and heart failure ranged widely from about 15% to 90%. So either 1 out of every 10 patients with heart failure had frailty, or 9 out of every 10 had frailty. So to help us firm up a better understanding of the prevalence, we conducted a meta-analysis in 2016 on 26 studies that reported some prevalence of frailty. And we included both multidimensional frailty and physical frailty. And so here's the forest plot of this meta-analysis, and we showed that about 45% of patients with heart failure are considered frail when taking into consideration all of these studies. And the prevalence was pretty similar for both multidimensional frailty and physical frailty. And this estimate lines up with the prevalence estimate reported by other groups, including Dr. Eric Fung's group and other studies that have followed. A few other key points I want to mention is that we've also found that frailty affects women more than men in heart failure, which is similar to findings from the broader frailty literature. However, frailty in heart failure is not always associated with NYHA functional classification or age. So it's very complex. There's a lot going on here. So the second thing that we have established in this field is that frailty is clearly associated with worse outcomes. And I think this goes to kind of catapulting this field because we have seen that frailty is linked with poor outcomes. So on the left-hand side, you can see the forest plot of the effect size of the relationship between frailty and mortality in heart failure, the effect size being the hazard ratio of death. And so across 29 studies, frailty conferred about a 48% increased risk of mortality in heart failure. And in subgroup analyses, this mortality effect was significant for both outpatients and inpatients. And then other meta-analyses have also shown this, including this one by Dr. Eric Fung's group, who showed that there was a 1.5-fold increase in the adverse outcome of death or incident hospitalization associated with frailty and heart failure. So very similar results. And then on the patient-reported outcomes side, fewer studies have looked at this, but signals are emerging that frailty confers worse symptoms and quality of life for frail patients with heart failure compared to those non-frail. So our group recently showed that frailty was associated with worse quality of life, particularly physical quality of life, among patients who are frail compared to those who are non-frail. We've also previously shown that frailty is associated with worse dyspnea, worse sleep-wake disturbances, and worse depressive symptoms. And the references are up here. So we've seen that frailty is very important in patients with heart failure, conferring both worse clinical outcomes and worse patient-reported outcomes. So a little bit about some unknown territory, the causes of frailty and heart failure. If only we knew what was going on, it would make it very much easier to manage this syndrome. So the mechanisms underlying frailty are really not well understood. They're mostly speculative based off of juxtaposing what we know about the pathophysiology of heart failure compared with the pathophysiology of frailty. We're starting to unravel some of these causes, and my group has been interested in figuring this out. So in a study that we published a few years ago, in a sample of 113 patients with heart failure who we brought into the lab and provided a fasting blood sample and were assessed on physical frailty, we then in turn assayed 9 different biomarkers to capture 7 possible mechanistic pathways that are outlined up here, including neurohormonal activation, insulin resistance, inflammation, skeletal muscle dysfunction, adipose tissue dysfunction. So in this sample, about 42% of patients were considered frail, so very similar to our meta-analysis. And then after adjusting for potential confounding factors, we found that lower IGF-1, lower adiponectin, and lower myostatin were associated with physical frailty compared to non-frailty. So of course, this is a very small sample and further validation studies are needed, but this is helping us to elucidate these mechanisms. So then how to determine if your patient with heart failure is also frail is very difficult given the multitude of measures. And I think the slide that Dr. Foreman put up is very exemplary of how all the different things that are out there and how do you choose. So similar to others, the frailty measures in heart failure fall into 2 camps depending on the focus. The physical frailty versus the multidimensional frailty. This is an audience who's very well attuned to where these camps lie. Across both camps, though, the syndrome of frailty is considered to derive from the system as a whole. And this is especially true in heart failure, where studies have shown that it is the cumulative effect of the frailty criteria and not any singular components. So there's been much discussion in the heart failure community regarding the use of first of all, which assessment tools to use, and do we apply screening or assessment tools to detect frailty? And this is especially important as we try to transition this to clinical practice. This is an example of a paper by Shirley Z and colleagues looking at the use of assessment and screening tools and compared these across a large sample of patients with heart failure. They found that of the screening tools, the clinical frailty scale had the best classification properties in detecting frailty. And then the assessment tools, which included both the frailty phenotype criteria and the frailty index, showed strong correlation with each other, suggesting that they may be reflecting a common phenotype. So there's definitely some overlap between the assessment tools and the screening tools, but it doesn't always capture everybody. So given that we have been stagnant in figuring out which assessment tool to promote or to suggest in patients with heart failure, a number of years ago, the ISHLT, or the International Society for Heart and Lung Transplantation, commissioned a writing group to put forward a consensus statement on the assessment and management of frailty, specifically in advanced heart failure. And this is a population of patients in which we really do need to ascertain the level of frailty, because it'll help to dictate the treatment strategies that we deploy. So I had the privilege of leading this consensus statement along with my project co-leads, Dr. Sunita Jha, Dr. Joanne Lindenfeld, and Dr. Peter McDonald. And we had a wonderful group of individuals, researchers, clinicians from across the world putting this together. So I'll highlight a few key points that emerged from this consensus statement. So first, I want to emphasize just the challenges of ascertaining frailty in heart failure. And I think this goes to Dr. Foreman's point about just, you can't simply look at a patient and determine that they're frail, because patients with heart failure especially may not exhibit the traditional form of frailty that is commonly pictured, especially like, for example, that experienced by my grandfather. So here's two examples of phenotypes of frailty in patients with heart failure. So on the left, you have an older woman who, with non-ischemic etiology of heart failure, likely due to hypertension. She has heart failure with reduced ejection fraction, which is very tiny. She has AFib in addition to her heart failure. And when assessed on frailty, she meets 3 out of 5 of the criteria using the frailty phenotype criteria. So is her frailty mostly due to heart failure, age, and comorbidities? Perhaps, but we don't know for sure. And then on the right-hand side, we have another patient, a young man who has non-ischemic etiology due to past drug use, also have FREF, but is morbidly obese, but without many other comorbidities. He also meets 3 out of 5 of the criteria. So is his frailty due to heart failure and obesity? Perhaps. So the bottom line is that both of these patients are frail, but do we approach them the same way? And the answer is probably not. But I also want to highlight too that frailty in patients with heart failure presents across the lifespan, presents across the spectrum of BMIs and across the spectrum of heart failure severity. So we can't simply just look at them to discern if they're frail. Another challenge is distinguishing frailty from different domains and related concepts. And this is another area that's probably familiar to this audience, is distinguishing things like sarcopenia, cognitive frailty, psychological frailty. Where do we draw the conceptual line around frailty? Does it just include the physical performance measures, or do we add in closely related domains? And this is even more problematic in heart failure because many patients, specifically with advanced heart failure, have lots of comorbidities. So in our consensus statement, we said, well, based off the evidence to date, given that most studies have looked at physical frailty and have validated these measures, we first recommend that patients with advanced heart failure have a physical frailty measure or assessment done, but then strongly consider other additional domains, as these can help ascertain the overall vulnerability of these patients. And then here's the specific table that's a little bit busy, but you can look at the paper for more details, but this is our recommendation for a proposed measurement tool. Again, we first recommend that all patients with advanced heart failure, especially those who are undergoing advanced therapies like left ventricular assist device implantation or heart transplantation. So we suggested a modified version of the frailty phenotype criteria, which has been widely used and validated in this population, along with the scoring and then some optional approaches to consider for research or for taking a deeper dive into each of the criteria. And then we also have some other suggested assessments to consider, as well as recommending the Frailty Index if doing some screening approaches for large data sets or medical records. All right, so the management of frailty and heart failure. So it's going to be very difficult to approach this. Knowing that a patient is frail is the first step, but then what to do next is very difficult. So I thought I would approach this as two perspectives. How do you manage the frailty in the patient with heart failure? And then how do you manage heart failure in the patient with frailty? So in other words, are you trying to use something like exercise or nutrition interventions, or even cardiovascular interventions to address frailty in the patient who also has heart failure? Or are you trying to manage heart failure in the patient who also happens to be frail? Are you using guideline-directed medical therapy? So I pulled these apart just a little bit, but it's probably not an either or, but a both because of the bidirectionality. So one way to approach the management of frailty in a patient with heart failure, first of all, is to identify the potential causes of frailty and heart failure. And so this is the figure from Dr. Kelsey Flint and colleagues that was published in 2012 that introduced this idea of LVAD responsive frailty versus LVAD non-responsive or LVAD independent frailty. And so I kind of expanded this out and included the cardiovascular causes versus non-cardiovascular causes, because I think it's the amalgamation of these two different causal buckets that lead to the middle portion of frailty, or the common pathways and then manifesting as frailty, very similar to that figure by Jonathan Affolalo. And so differentiating between these buckets is very important in telling us which therapies will help ameliorate frailty. So here are a couple of key points to make from this. So one way to manage frailty and heart failure is by addressing the cardiovascular causes, such as through an LVAD or heart transplant. And this is a systematic review by Peter McDonald's group that goes through the different approaches to prevent or reverse frailty. And so they summarize the literature to date, and here are a couple of key points. For LVAD, it seems that frailty improves for some, but not all. So definitely it does improve, but again, it doesn't improve for all patients. And it seems to improve mostly at that 3-month time frame and beyond. In terms of heart transplantation, there's a study that has examined this, and they found that of the 13 patients who were frail prior to heart transplantation, none of them were actually frail at follow-up. So frailty does seem to improve post-heart transplantation. But it's frailty. So frailty may be improved with the use of LVAD or transplantation, but it's not going to be the silver bullet strategy, considering that there's multiple causes of frailty and heart failure. There's also prehabilitation that others have looked at. Very few studies have looked at this, only 2, one in cardiac surgery and one in heart transplantation, and both showed improvements in frailty and functional capacity after, but this was a limited sample size. So I think prehabilitation is another area for future research. And then Dr. Foreman already mentioned this, but there is definitely some growing evidence in terms of rehab. There's been a few prospective RCTs, including that landmark rehab heart failure trial, which tested that transitional tailored progressive rehab intervention that included those 4 domains that he mentioned. And they found again that after 3 months, the intervention group had significantly greater improvement in the short physical performance battery score than in the control group. And then what I found very interesting is that in a pre-specified secondary analysis, in this paper published in JAMA Cardiology, they found that those heart failure patients with worse baseline frailty status had actually more significant improvement in physical function compared to those pre-frail. So perhaps the frail patients actually benefit the most from these interventions. So going back to our 2 patients, when you apply some of these interventions, are we going to ameliorate frailty? It's really hard to discern. So if you have the woman trying to figure out what are the causes of the frailty in her and which therapies will shrink that frailty bubble is very difficult. So trying to figure out where these patients land is hard. And then the last point I want to raise is how to manage heart failure in a patient who is also frail. So taking that second perspective I described earlier. So what do you do when you're trying to manage heart failure in that patient who is also frail? So I want to mention two studies, one by Kahn and colleagues that used a trial data set. They found that patients with heart failure with reduced ejection and a higher burden of frailty were actually less likely to be initiated on GDMT and have dose escalation per guideline targets, despite them being actually at increased risk of adverse events. And then another study also found, this is by Kondo and colleagues, they showed lower utilization of GDMT as the level of physical frailty increased. And moreover, suboptimal use of GDMT, regardless of frailty, was associated with worse outcomes. So frail patients, they actually still benefit if you put them on the right GDMT, the right medications. However, they're just underutilized, and we don't know why. Is it provider bias? Is it resource allocation? We need to understand this more in future research. And then lastly, in terms of decision-making around advanced therapies like left ventricular assist device or transplantation, I want to mention that frailty is not a contraindication, but it is a consideration as one component of many in the evaluation of these patients. So here are my take-home points. I just want to emphasize that frailty is very common and associated with worse outcomes. This has been well established. We're moving forward in terms of recommending assessments of frailty in patients with heart failure. I think all patients with heart failure should be assessed on frailty. The causes of frailty and heart failure are multifactorial, so we really should approach the management of frailty from that multifactorial perspective, and they should be co-managed considering the bidirectional relationship. So I just want to thank my lab, my mentors, co-Is, and collaborators, and this is my funding. And I did not have any conflicts of interest to disclose. I have some research funding that does support some of this work. Thank you very much.
I think I'm up next. Thanks very much, Dr. Denfeld. I'll just share my slides. My name's Oliver Todd. I'm based in the UK. So I thought it might be worth giving a bit of context, given our systems are different, context for the work that I'm going to present. I apologise at first for the shocking image, but it gives the context for why I was interested in frailty myself as a clinician working at the front door in emergency department of our hospital, whereupon I saw a lot of people falling over, breaking their hips, and often had with low blood pressures in their primary care records on further investigations, despite being on multiple antihypertensives. So I was interested in the management of hypertension according to frailty and whether or not we should consider frailty status when managing hypertension. I'll just give that context. I'll come back to hypertension. But my presentation today will briefly touch on some of the work which I'm much more peripheral to of my colleagues, Andy Clegg and James Shepherd, who I'll mention later on, around frailty and the screening of frailty and interventions to prevent and act on frailty in the UK health system. My work is funded by NIHR, which is, I think, broadly the UK equivalent of NIH. I have no other conflicts of interests to declare. I'll briefly speak about the UK context, frailty assessment and management in the UK health system, successes and limitations of this approach to date, and a worked example on with a focus on hypertension management, which will hopefully illustrate next steps as I see it and those in my group see it. So briefly, the UK is made up of 4 nations, and actually the National Health Service, which is a universal health service free at the point of need, is different in each of those 4 nations. Those 4 nations being Northern Ireland, Scotland, England, and Wales. Sometimes I think they say in the States that you need to follow the money to understand the system. The UK economy is about 3 trillion. That compares to the American economy. I think it's 23 trillion. The tax revenue, or the UK state, has approximately 1 trillion to spend, and about 20% of that goes into health and social care, the majority of which goes directly to NHS, and the majority of that to clinical commissioning groups. So broadly, the NHS funds the primary care practitioner, the family doctors, pharmacists, dentists, and then local groups will commission broader services, so emergency services, community services, and rehabilitation. Social care is separately funded, although there are efforts to integrate the two, and that's approximately 1% of total government spend is on social care. I illustrate that context just to describe how frailty has been approached within this. So it's probably the most important thing to note is that primary care delivered via GPs, or what I think are known as family doctors in the States, are essentially the gatekeepers to secondary care. You cannot get to secondary or specialised care without first going via the GP. So 90% of patients' contact within the health service are via the GP. And now all GPs have established electronic health records, and that's been the case more or less since the 1990s. And broadly, there are 4 system suppliers. So there's a lot, it's a very centralized system essentially, and that gives scope to screen frailty system-wide. Important also to note probably is that geriatric medicine, I think in contrast to other countries and in the States, is the largest hospital specialty of internal medicine. And that geriatric medicine is highly integrated at a policy level within the NHS. So a national clinical director for older people in integrated care is a key leadership role within NHS England. And that's been integral to the work that I'm going to describe. I'm going to describe frailty prediction models using routine care. These are broadly prediction models using routine data from those primary care systems to develop predicted risk of a person's risk of developing outcomes in association with frailty, so as that we can identify appropriately people who may benefit from interventions, for example, comprehensive geriatric assessment, falls prevention, and anticipatory care. The Electronic Frailty Index, developed in 2016, is based on the cumulative deficit model that was authored by Ken Rockwood and colleagues. People are probably familiar with this, but it uses a number of deficits, 36 deficits, and which is the denominator. The number of deficits you have is taken as a fraction of the total, and that has been shown to be a good predictor of all-cause mortality, hospital admission, and care home admission. In this way, because it was mandated that GPs screen all of their their patients in their local area according to their frailty status, they were then able to target people according to their frailty status for holistic management, supported self-management, for example, in those with mild frailty, care and support planning in those with moderate frailty, and comprehensive geriatric assessment in those with severe frailty. And this was rolled out into national guidelines. So the NICE, National Institute for Health and Care Excellence, are our main guideline providers in the UK, and that mandated frailty screening. And indeed, that was then financially reimbursed, so that GPs were reimbursed for screening for frailty. And those are the main system providers of those primary care electronic health record systems, which were also brought on board early, so as to enable easy screening at primary care level. There are some successes. So within a year of that being rolled out, 1 million people were identified according to frailty status over the age of 65. 200,000 were identified for a falls prevention pathway. So it enabled targeting of services to those most at need. However, there are also possible limitations to this approach. Population screening, there is the risk, whereas frailty is clearly on a spectrum and heterogeneous, of broadly categorizing people as frail, so that particularly in contexts of resource shortage, as was experienced in the context of COVID-19 pandemic, people were identified as frail and may have not been offered treatments that they could have benefited from. There are problems with methodological problems with this approach. There's temporal drift, as I've illustrated in that graphic to the right, whereby the prediction model, which has been trained on data from the early 2010s, is no longer accurate when practiced on people with a different demographic different BMI, different ethnic mix in 2020 or 24, indeed following the pandemic. There are also problems in using these frailty indices in research, for example, reverse causality and other complications. A population-based approach may not always be person-centered, and there is a risk when we've done qualitative research, as I have done, that people might find that being labelled as frail leads to a nihilistic approach, and the concerns that were highlighted by the former two speakers. Indeed, a more shared decision-making approach may be more appropriate, and I hope that I will now go on to talk about some of the solutions, some of these limitations of the work to date. Indeed, the Chief Medical Officer, which is again a high office of state in the UK, released a report at the end of last year identifying some of these challenges and potential solutions, and recommended at the highest level of government really that we now target interventions according to predicted risk using frailty and other models, model impact of interventions on people living with different frailty levels, and reanalyze trial data using individual patient data meta-analysis to investigate how treatment may vary across the frailty spectrum, modeling these findings in large routine data sets, which are potentially more generalizable. I want to give a worked example of hypertension, which touches on the context which I alluded to in my very first slide. So antihypertensives, as may be familiar to those listening, have benefits and harms. It's clear that antihypertensives, in terms of absolute risk reduction, demonstrate increasing benefit with increasing age. And this forest plot shown above is drawn from a Lancet paper published a few years ago now, demonstrating using meta-analysis, IPD meta-analysis of 51 randomized controlled trials in blood pressure lowering. And it identifies increasing absolute risk reduction the higher the age. So in line with Dr. Foreman's first presentation, increasing benefit from blood pressure lowering with increasing age. In the second forest plot below, with the coloured forests, I'm drawing upon data which is from a routine data set of approximately 4 million UK participants, which is more generalizable than those randomized controlled trials and has greater external validity to the patients in whom we apply this evidence. It demonstrated similar benefit from treatment, but it also demonstrated increasing harm. So that although on a population level, harm from antihypertensives is generally very low, those harms are higher in subpopulations that are defined by age. And although I'm not showing these forest plots now, that paper also stratified by frailty status and demonstrated increasing harm from antihypertensives in terms of falls, but not only falls, also acute kidney injury and electrolyte disturbance in people with advancing frailty. Sorry, I do demonstrate that here. So I have got the forest plot there according to frailty status, and I'd strongly commend that paper to you. So this, in terms of next steps, we're increasingly moving towards more refined prediction models. So not only frailty, but frailty plus. So looking at, for example, Q risk for prediction of cardiovascular risk. So looking at absolute risk reduction, but in addition to that, what is someone's absolute risk of cardiovascular disease? But alongside that, to also consider in shared decision making, what is that person's absolute risk of falls? And how may that be added to by an antihypertensive, for example, in this context, or what their absolute risk of acute kidney injury is, and how may that be added to by a new antihypertensive treatment. I've just broadly mapped out what may be a sort of hypothetical shared decision-making tool for antihypertensives in the context of frailty. Advice for people who are maybe not used to looking after older people to invite caregivers, particularly people to support patients with fluctuating mental capacity in sharing decision-making, ideally meeting more than once, giving time for questions and providing takeaway information to give the patient and their caregiver time to discuss this difficult balancing of risk. Discussing different treatment options, including doing nothing alongside lifestyle changes. and consider presenting treatment benefit and harm in terms of absolute risk reduction using prediction models, as I've demonstrated, which use those absolute risks. I'd like to just move on slightly to where I see deficits and the need for further research. That CMO report that I alluded to also called for a greater need for really investigating the underlying etiology of frailty and where it mixes with cardiovascular disease in this new cohort of older people who are surviving now with frailty that we simply did not see 20 or 30 years ago. I think this alludes to the two previous speakers' points. Interestingly, just a week ago, a new review of the ASCOT trial demonstrated that blood pressure variability is the key risk factor for cardiovascular disease. And that's the real challenge that we see in people with frail, that they have increasingly variable blood pressure, and we don't know exactly what to do with it. That's led me on to my own work, which has been recently funded for the next 5 years, to look at how blood pressure variability can be investigated using ambulatory blood pressure readings, so 24-hour BP readings, and home BP readings to investigate the effect on falls alongside cardiovascular risk. And I'll be developing a new platform whereby we have up to 28,000 people's 24-hour BP profiles and looking at how we can predict risk in this cohort. So looking ahead, I think frailty measures using routine data can predict key frailty outcomes with robust model performance. We now need more refined tools for looking at different contexts. And a key question is, how does care informed by frailty measures lead to better patient outcomes? We need to develop methods to monitor and update the performance of these frailty measures over time. So just leaves me to thank my colleagues, which is a massive team, and particularly those colleagues I mentioned whose work I've drawn upon, James Shepherd and Andy Clegg. Thanks very much for your time and listening.
Thank you, everyone. I think I really enjoyed my colleagues' talks, and but we're about at the end of the time for our webinar, so we're not going to have time for questions, I'm afraid. But I will thank everyone for participating in the webinar, and I'd like everyone to know that the next webinar is on Wednesday, March 13th. Ariella Orgaby, who I mentioned as part of my talk, will be talking about the VA Frailty Index. And if you are a clinician practicing in the USA or Canada, you can claim AMA PRA credits. You'll receive instructions at the end of the webinar. Thank you very much.